This podcast contains our own personal views, not associated with any organisation. Coronial contains descriptions of death inquests that may be graphic and disturbing to some listeners. Discretion is advised. Welcome back, everyone, to Coronial. I'm Alice.
I'm Georgie.
I'm Emma.
This week I'm going to be telling you about the inquest into the death of Annette Maxfield, who passed away on the 24th of November 2004 at Mount Isa Base Hospital. This death was reportable because it was related to healthcare. And so that's why the coroner investigated. Annette was born in 1942 in Ipswich, Queensland, so she was 62 when she died. And she moved to Mount Isa in 1972. She married her husband in 1974, so had been married for 33 years at the time of her death. She had 7 children, 5 from a previous relationship and 2 with her husband, and 4 grandchildren.
That's a lot of children.
Rock on.
Yep. She had worked a variety of jobs and had a large group of friends. She was quite a social person. Firstly, we'll go through Annette's medical history, and it is reasonably lengthy. When she was 19, Annette had her gallbladder removed. By the time she was 21, she had given birth to 5 children.
Woof.
So those first 5 children were...
Were there multiple pregnancies? Like multiples?
It didn't go into it. No, I'm not sure.
That's early to start.
She had another 2 children by the time she was 30, when she developed gynecological problems, which caused her to have a tubal ligation in 1972 and a hysterectomy in 1976. Annette developed bladder dysfunction in the mid-1980s, so had several surgical and exploratory procedures. She had a small bowel obstruction which led to bowel adhesions, which never completely resolved, and they never really figured out what underlying cause of that was.
Yeah, but she'd had several surgeries, right? So the bowel adhesions were probably just post-surgical related, right? Yeah. Surely.
One of the specialists she saw in 1989 thought that she may have hysterical pseudo-distension because the condition resolved when she was sedated or anaesthetised.
I love all medical things that have hysterical in them.
Uh-huh. In the 1990s, Annette had surgery to repair problems with her bladder and rectum, which was possibly needed because of her multiple births. In 2001, she developed intense perineal pain and fecal incontinence, which led to a whole bunch of investigations. The director of surgery at Mount Isa Base Hospital referred Annette to a gastroenterologist at the Townsville General Hospital, who recommended magnetic resonance cholangiopancreatography, a medical imaging technique which uses MRI to visualise the biliary and pancreatic ducts non-invasively. The scan showed no abnormalities that weren't already consistent with her surgical history in that she didn't have a gallbladder.
Okay, yeah.
In the gastroenterologist's report, he noted a hazy previous history and some inconsistencies in her history.
Yeah, because she's had like 20 procedures in her life already.
Yeah.
She doesn't remember every single detail of all of them.
Exactly. A colonoscopy in Mount Isa also didn't find anything abnormal. Anorectal manometry and ultrasounds were done in Townsville, which suggested
Why
that...
is she travelling all over Queensland?
Oh, just because of the services that are available.
Mount Isa doesn't have
They don't have
much
anorectal monography or whatever you just said.
manometry.
Manometry.
Oh, sorry. Is she I thought she was from Ipswich.
No, she grew up in Ipswich and then she moved to
Then
Mount
she
Isa
moved
with
to Mount
the
Isa.
second husband to have the
Sorry,
subsequent children from
must
30.
have missed that.
Can you explain to me what a
Manometry?
manometry is?
Look, that is a great question. Let me do a quick
Oh, no,
Google.
I can take care of that way.
Is a non-invasive procedure to evaluate the function of the rectal and anal muscles.
Oh, okay. So, okay. Yep, sure.
So yes, those were done in Townsville, which suggested the fecal incontinence was due to a defect in the anterior of the external anal sphincter.
Due to pregnancy, she must have had a tear.
Yep.
Yeah, so surely that's got to be just because she's
had
Had
7 babies.
Yep. In June 2002, Annette underwent a sphincter repair by a colorectal surgeon at the Townsville Hospital, but the wound split after 3 days, so this didn't actually treat the issue.
Yeah.
The surgeon would have preferred that Annette first try anorectal biofeedback therapy to develop better sphincter control. So this is where you do a series of pelvic floor exercises and your results are shown via a digital monitor.
So Kegels.
Basically, but with like feedback clearly visible so that you know whether you're doing them right.
Fair, okay.
Yeah. He didn't think that the surgery would be successful and was not able to tell the coroner why Annette refused to take the sort of exercise step first before surgery.
Because laziness. I mean, that would be the way I'd go.
Yeah, like you're sick of dealing with this, you just want it fixed.
Yeah.
Yeah.
I could do that thing that's going to take me effort, or you could just fix it for me. I chose that one.
Yeah. In November 2002, the surgeon at Townsville Hospital performed a colostomy. So this is where the colon near the rectum is cut and the end is brought out through an incision in the abdomen. The other end is closed, which means that the rectum and the anus are not used anymore.
Yeah.
So Annette recovered well initially, but then developed abdominal pain, increased heartburn, and water brash, which is the spontaneous flooding of the mouth with a clear, salty fluid.
What?
I had never heard of that before.
Gross.
No.
Yeah.
That's a thing people can get?
Apparently, yes.
Oh. How much? What volume?
I don't know.
Okay.
Super bizarre. A gastroscopy was done in December 2002 to investigate this, and so that's where the inside of the stomach is inspected using a camera and a light, but there were no findings from this. In August 2003, the surgeon found that there was an unusually tight band of sphincter muscle in Annette's anus, and he thought that division of the anterior anal band would help with the abdominal pain. And this procedure was done on the 13th of October 2003.
Okay.
Annette also saw a gynecologist in December 2003 because of pelvic pain, but nothing conclusive was found. So yeah, pelvic pain, abdominal pain.
Everything hurts.
Yeah, basically.
Because of her large number of surgeries and things. Okay.
Annette saw the surgeon on the 16th of January 2004 and was complaining of pain and tenderness in her perineum. He referred to the colorectal surgeon, the one in Townsville, for advice on performing an abdominal perineal excision and whether that could be done at Mount Isa Hospital.
Hang on, an abdominal perineal excision. So taking out your perineum via the abdomen?
It's removing essentially the remnant of the colon and your rectum and anus.
Right. It's
So removing that last bit that was still there in the thought that that would reduce her pain.
Okay.
The colorectal surgeon said a conditional yes to the first part in that you could do that procedure, but he didn't answer the part about performing the surgery in Mount Isa. Because essentially the surgeon at Mount Isa was like, is it a good idea to do this? And can we do it at Mount Isa Hospital?
Right.
And
he was like, yeah,
the
sure, you
colorectal
could do
surgeon
it.
said, yeah, that is a procedure you could do, but he didn't say anything about whether or not it should be done at Mount Isa or Townsville.
Foreshadowing here.
Yep.
Mm-hmm.
The colorectal surgeon saw Annette in March 2004, but was not able to examine her fully as any touch to the perianal area caused her intense pain. He responded in writing to the Mount Isa surgeon, stating that the perineal resection was appropriate, but recommended a number of tests to be done first to exclude other causes. So he recommended another colonoscopy to exclude the possibility of inflammatory bowel disease. He also recommended an MRI to exclude the possibility of a tumour, and a psychiatric review to make sure she fully understood the risk of persisting perineal pain, even if the surgery was performed.
Yeah, because like there's, at this point, surely she's had heaps of procedures. She's always ended up with pain in varying locations across varying time points. So like there's surely a risk that that one single procedure is not going to fix everything.
Yeah, exactly.
Yeah, okay.
He said that he discussed other options with Annette, but she was adamant that she wanted surgery. However, during the inquest, his opinions about the treatment course were varied, between it not being his preferred choice to not strongly disagreeing with it.
Okay.
So he's sitting on the fence there being like,
Yep.
I don't know if I did or didn't want to do this.
Yeah.
Okay.
In his letter back to the Mount Isa surgeon, he wrote, I agree with you. The best option under these circumstances would be the removal of the rectal stump.
So at the time he
He agreed that
at
that
the
was
time he wasn't sitting on the fence. He's like, yeah, let's do this.
Yep.
Okay.
The coroner concluded that his stance on the issue was that it was likely Annette had some sort of inflammation or infection in her perianal area, and keeping in mind the extreme pain and her unwillingness to attempt other treatments, the surgery was not unreasonable.
Fair.
Mm-hmm.
Annette went back to the surgeon at Mount Isa Hospital on the 16th of April 2004, and that surgeon also received a letter from Annette's psychologist of 2 years. It noted that Annette understood that the surgery will not guarantee any relief from the pain and may even make her condition worse, but that the pain she was dealing with now meant that she was willing to go ahead with the surgery and give it a go.
It sounds like she had a pretty reasonable understanding then. That's good.
Yeah.
Okay.
Colonoscopy was done on the 16th of June 2004, which found some patchy colitis, which is inflammation of the colon, but didn't explain the ongoing pain. Annette saw the surgeon again on the 3rd of August 2004 and advised him that she wanted the radical perineal resection, so the removal of the rectal stump, as soon as possible. The surgeon said during the inquest that he wasn't confident that the surgery would resolve Annette's pain, but it was the only treatment option left. In a letter written to the coroner, he said, quote, "I was not at all keen to embark on this surgery, but I allowed myself to be persuaded." So the surgeon thought that the colorectal surgeon would have investigated the possibility of neuropathic pain and referral to a pain management specialist. And the coroner found it surprising that a pain specialist was never consulted, considering Annette's long history of abdominal surgeries and ongoing pain.
Yeah, but did the coroner look into whether a pain service existed in Mount Isa?
I don't think so. I doubt there would have been one in Mount Isa, but maybe in Townsville.
Yeah, which would have
there would have been if she was already going
and
to Townsville to see the colorectal surgeon.
Yeah, fair. But I don't know. I just think it wasn't a service available there, so.
But it wasn't even thought of as a possible cause for this pain.
Yeah,
like
fair.
Neuropathic pain surgery is not going to fix that.
No, not at all. Yeah,
at all.
fair.
So, why didn't they look into more non-surgical options?
Yeah, and pain management options that were not your classic opioid pain management, and there are other alternatives that are going to treat neuropathic pain that you could try. Yeah.
Annette was scheduled to have the abdominoperineal excision of the rectum, APER.
Yes.
APER.
Sure.
Yep. On the 24th of November 2004 at Mount Isa Hospital. 2 days before the surgery, she attended the hospital for a pre-op assessment. A general history, including current medications, was taken, and her vital signs were measured. It was noted that she drank alcohol every day, but blood was not taken for a blood test or blood matching.
Is she drinking alcohol to numb her pain?
Probably. I wouldn't be surprised.
Yeah, so she's also using other things.
Self-medicating.
Yeah.
On the morning of the surgery, Annette arrived at 7 a.m. Her vital signs were checked again, and it was noted that she had a heavy intake of alcohol, ethanol 55 ounces daily average every day. And as a conversion, that's basically 1.5 litres. When they say ethanol, I think they just mean alcohol in general.
So not like it wouldn't be the equivalent of pure
But is that
ethanol?
1.5 litres of wine or 1.5 litres of vodka?
No idea.
That needs a very specific specification because those are very different in terms of alcohol
but
content.
even 1.5 litres of wine is a lot.
Agreed.
That's
but
a lot of
1.5
wine,
litres
but
of vodka is much,
more.
much more.
They didn't talk about how many standard drinks
Yeah.
she had every day, which is probably a better indication.
Yeah.
But this is 2004. Did standard drinks on bottles exist at that point?
Oh, maybe not.
I don't know.
Yeah, that's true. The anaesthetist examined Annette and took a brief history, but didn't read her charts or the pre-op assessment notes.
No. As an anaesthetist, you need to know how much they drink.
Yep. He noted that she was a regular social drinker, which he interpreted as a couple of drinks every couple of days.
Is that what a social drinker does? That still seems excessive.
That seems a lot for I would think a social drink would be like drinks
On
once a
weekends.
week.
Maybe,
Yeah.
if not like a few times a month. And a couple of drinks at social drinks? That's not how that works in Australia.
No, that's true.
If you're having social drinks in Australia, you are binging like 10 standard drinks at a time.
You're doing an FG. That is social drinking.
Yeah. He told the coroner that if he knew what she'd told the pre-op nurse, if he'd read the notes, he would have ordered a liver function test. He did not order any blood tests to check Annette's hemoglobin or electrolyte levels, and did not do a coagulation profile or send any blood for a grouping.
That seems a lot for I would think a social drink would be like drinks once a week.
Yeah.
Yeah.
He told the coroner that if he knew what she'd told the pre-op nurse, if he'd read the notes, he would have ordered a liver function test. He did not order any blood tests to check Annette's hemoglobin or electrolyte levels, and did not do a coagulation profile or send any blood for a grouping.
I would have thought this was a major enough procedure that you would have pre-screened in case they had blood loss
Yes.
for this. Oh, yes. Yeah. I don't I
You
don't
would
know
think
how
so.
major this is, but I would have thought this is one of those ones that you would just like do it just
Yeah.
out of safety
So that you've done
precautions.
it. Yep. Just to double check everything's okay.
Yeah.
Absolutely.
Okay.
The anaesthetist had some trouble inserting a cannula and ended up inserting one into the right internal jugular vein, which is in the neck. And he didn't insert an arterial line.
Did the coroner say whether that's standard or not standard for this kind of procedure?
He didn't.
Okay.
The surgeon had a second-year junior house officer as an assistant in the surgery. The anaesthetist was a GP with a Fellowship of Rural and Remote Medicine. He was a medical educator and also acted as an anaesthetist 1 day a week at the Mount Isa Hospital.
Yeah, that's pretty standard out there.
Yeah. Although he had a lot of experience in anaesthesia, he was not a specialist anaesthetist, and he also had a junior doctor as an assistant. The surgeon said that he planned to remove the anus, rectum, and remnant colon via perianal incision, and only make an incision in the abdomen if he was unable to complete the operation from below. He made incisions on either side, so anterior and posterior of the anus, and used specific retractors to be able to see what he was doing when he was dissecting away. As he dissected further, he kept close to the bowel, which he thought reduced the likelihood of severing unseen blood vessels. His report stated approximately 30 to 40 centimetres mobilised from below without approaching the closed end of the rectal stump. So essentially he's like exploring up, but he hasn't reached the end of the
loop yet.
Yeah. And at that point, he couldn't clearly see what he was doing.
So he pressed on?
Yes, but he changed tack a little bit.
Oh, good.
So about an hour after the surgery started, he temporarily closed the perineal incision and made an abdominal incision to be able to go from the top there. It took about an hour to free the colon and divide the blood vessels and tissue tethering the rectum in that abdominal incision.
Okay.
When the surgeon returned to the perineal incision to remove the bowel and the rectum, he was surprised to find significant bleeding.
Oh.
Yep.
So he'd just been filling that cavity with blood the whole time he'd been doing that?
Potentially.
Oh.
Yep. So although Annette's blood pressure dropped from 90/60 at 1:50 p.m. to 60/40 at 2 p.m., which is around the time that the bleeding was noticed, her blood pressure had actually dropped to lower levels much earlier. So between 12:25 and 12:40, her blood pressure dropped from 90/55 to 65/40. It returned to 120/70 for 5 or 10 minutes around 1 p.m. and stayed around the 80/55 and 90/60 until that drop at 2 p.m.
Was no one getting worried about 90/60?
Apparently not.
Yeah, that seems low, hey?
It seems a little bit low. I don't know what you want it to sit at during a surgery, though. Maybe you wanted it to sit a little bit lower because you don't want there to be much bleeding.
Around. Yeah.
But, okay.
Yep. The surgeon completed the removal of the rectum and was able to see the blood welling up in the presacral region. He applied pressure with his hands and packs, and he applied sutures and forceps to try and stop the bleeding, but he wasn't able to successfully find the bleeding vessels.
Oh.
So he wasn't able to localise where the bleeding was
coming from. And you said he had
from.
a bad view at that, like in that area when he first started and that kind of stuff,
and like,
that's why he switched. So, okay.
And the fact that there's now blood everywhere makes it so much harder. The notes from the operation stated, bleeding located to multiple flimsy wide-bore veins in hollow of sacrum, but in the inquest he said that he couldn't say for certain where the blood was coming from.
Yeah, okay. The
bleeding continued, so the surgeon decided to fully pack the abdomen and pelvis and close both wounds, which was done just after 4 p.m.
That's still a while. This is like 2 hours into that, right? Oh, no. You said he swapped at 2 or something, so.
Her blood pressure dropped at about 2 p.m.
Yeah, okay.
And I think he'd already been in the surgery.
But 2 hours
for 2 hours.
Noticed. But 2 hours since he noticed that she was bleeding.
Yes.
Yeah, okay.
Yep. Obviously, with blood loss, you want to be replacing this blood with blood transfusions.
Yeah, I was going to ask at any point, did someone do a group and hold and give her some blood?
But there was a delay of 1 hour and 10 minutes between 2:50 p.m. and 4 p.m. before the first blood was transfused, and a blood test wasn't ordered until 3:20 p.m., an hour and 20 minutes after the bleeding was noticed. So there was a delay in giving her blood when they knew that she was bleeding.
Yeah, right.
A second unit of blood was transfused at 5 p.m., an hour after the first. The first unit of fresh frozen plasma was only transfused at 5:10 p.m., and it took 3 hours to transfuse that unit. And in total, she was only given 6 units of plasma. Annette needed O-negative blood since there was no cross-matched blood available.
Mm-hmm. And I would hope that Mount Isa Hospital is big enough that they have some
Yeah,
O-neg
that's what I was
units
thinking, like
just
how
chilling.
many...
Please be
much
more than
blood
2.
do they
Please be more
have?
than... Oh, no, she got 6 units. No, she got 6
6 units of plasma.
Please tell me they had more than 2 units of O-neg.
I don't think they necessarily
Did.
Or they didn't
give it.
say.
Yeah,
Yeah.
okay.
The anaesthetist didn't draw blood from Annette before giving the blood transfusion, which meant that getting cross-matched blood in theatre was delayed.
The moment you transfuse someone else's blood in, you then have that other person's blood contaminating it. So then if you try to match it with a new product, you are unfortunately matching both the person who's the patient along with the person
donor's
who's
blood.
the blood came from.
Yeah.
And that makes it incredibly difficult to then match it.
Yeah, so ideally you want to, ideally you would have already done this when she was admitted or pre-op. Annette receiving a blood transfusion meant that she should have also been receiving IV calcium or calcium gluconate to compensate for the effect of donor blood on coagulation factors, and that wasn't done.
Sure.
No further blood tests were done after the one at 3:20 p.m. The anaesthetist said that that was because he knew the results wouldn't be good and it wouldn't change his management of the situation.
Ooh, I get that to a point, but if her hemoglobin was like nothing,
Exactly.
you would just keep giving red cells.
Yeah, exactly.
Okay.
Furthermore, a coagulation panel wasn't done until 5 p.m.
Which again would have been important, especially because she wasn't getting that other calcium gluconate.
Yeah, yep. Annette continued to deteriorate, so the anaesthetist contacted the director of anaesthetics at the hospital, but instead of taking over the situation, he was seemingly only there intermittently.
Okay.
So as the senior
person, he was like, you got this.
Yeah, he essentially didn't step up and take over the case and help out the more, still very experienced, but the more junior doctor. At 6:30 p.m, Annette was moved to the ICU. The bleeding was continuing and she was peripherally cool. She was given inotropes to try and raise her blood pressure, but this didn't work.
And do we know what her blood pressure is at this point?
No.
Okay. But presumably not.
Presumably,
Probably,
yeah, low.
Annette's husband came to the hospital at 7 p.m, while Annette was still alive, but obviously very sick. He's adamant that the surgeon said that the surgery was a success.
Sorry, go on.
And,
Technically, yes.
the thing that they were going to remove was removed.
Yes. Rectum is
But
gone.
I would not have called that a success.
It's not really the outcome that
Yeah,
you were expecting.
exactly. But in any case, he was also told that she was likely to pass away soon, and so he left the hospital very distressed. Understandably.
fuck?
Oh, yeah, that is an interesting take on how that could have gone down.
Uh-huh.
Oh, yeah, we removed the stuff that we were meant to remove, but she's probably going to die soon.
Yep.
Do you even bother talking about the success of the operation then?
Well,
versus
exactly.
It's irrelevant.
Yeah.
So as if you don't lead with, I am terribly sorry, she is going to pass away soon.
Yeah. At 7:30 p.m, Annette's heart rate slowed, and she was declared deceased at 7:50 p.m.
It doesn't, from what you've described so far, suggest that they were doing that much in that period of time.
It didn't really seem like it. They would have been transfusing plasma at least.
But why?
Because she got 6. Because the first
Because
unit
she's
of
gonna
plasma...
die.
Because her blood pressure is low, so they're trying to bring it up. But, it doesn't describe, has anyone checked her hemoglobin? They checked her coags at some point, and do we know if they were good or bad?
Yeah, well, they didn't do any blood tests after 3:20.
In the ICU?
And she died
Because the anaesthetist was like, well, no,
whatever.
the results are going to be bad.
So it doesn't matter.
So it doesn't matter. We're still going to be treating her the same.
But then why, if they're taking that approach, why are they giving her plasma?
I'm so confused.
Oh,
It doesn't sound like they're doing anything for this dying woman.
Not really. Oh, sorry, they did the coagulation panel at 5 p.m., but it didn't go into the results of that.
Okay.
And says the first unit of fresh frozen plasma was transfused at 5:10, and it took 3 hours.
But she was dead by 7.
No, I think it finished transfusing at 5:10. Yeah, the rate they were giving it to her at meant that it took 3 hours. And then she would have been given more after that, which led to the 6 units in total.
So they gave the first one in 3 hours and then gave the subsequent 5 in less than 2 hours.
Yeah.
Confusing.
Mm-hmm.
Okay.
Later that night, Annette's husband was brought back to the hospital by police, and he identified his wife to an officer. The death was reported to the local coroner, and Annette's body was flown to Brisbane for an autopsy.
So many horrific instances for this poor husband.
Yeah, I know.
Of so then also, we're going to need you to identify this body.
Yeah.
Oh, that's horrible.
And the inquest didn't go into the results of the autopsy, because I'm assuming nothing was found except for the fact that artery,
I assume
blood
everything
vessels
had
been cut, so...
Yeah, I assume it was consistent with what had been described around the surgery and stuff like that.
Yeah.
No surprising information was found.
So 2 surgical experts gave evidence at the inquest. One didn't think that the surgery would be likely to resolve the pain, but it was the surgeon's decision to make. The other said that the surgery was likely to resolve the pain by removing the anus, but considering Annette's history, pain was likely to occur in another organ.
That's brutal, but go on.
Yep. He said that performing the surgery without knowing the cause of the pain was an error of judgment, since her pain was a symptom, not a diagnosis.
It still shows, though, that even with 2 people, there was still a conflicting opinion around
Whether
what the
it should have been
management...
done.
So then it's really hard to say whether it should or shouldn't, because the answer is what's right for the patient at the time with the information you've got. So presumably the right answer for her was still the surgery. It's just the way they went about it.
None of the doctors who gave evidence in the inquest had ever performed that surgery to reduce or eliminate pain from an undiagnosed condition.
Yeah.
So the coroner concluded the decision to perform the surgery was inappropriate.
Okay. Yep. Fair.
The coroner noted that patients have the right to refuse treatment that is recommended, but they don't have the right to demand treatment, which the doctor does not think is warranted.
And this was in 2004 that this happened, right?
Yeah.
It's only gotten so much worse with the advent of social media.
Yeah.
And people come in demanding so many things. There's so many times of if you don't do it, they're just going to seek out someone who does anyway.
Yeah. The surgeon who performed the surgery had done the same procedure about 30 times over his 30-year career and about 20 similar operations, but not the exact same.
Huh. Wouldn't have thought it was that common. Okay.
The last time he had done it was about 2 years before Annette's surgery. He considered himself experienced and knowledgeable enough to do it, but did have some concerns about the ICU support in Mount Isa.
Red flag.
So the Mount Isa Hospital had what the coroner described as a high dependency unit rather than an intensive care unit.
Right.
An expert witness advised that they would expect a surgery of this type to be done in a hospital which had an ICU and the capability to deal with major blood loss by an experienced surgeon with a specialist anaesthetist.
Yeah. And sorry, to come back to all of her medical stuff was all mostly surgically related. She didn't otherwise have other comorbidities like blood pressure problems, diabetes, other things that would have made it more difficult to manage or concerning. No. Okay.
She just had, essentially had a bunch of surgeries and
ongoing problems.
Yeah. It was noted that Annette had a bad experience with the colorectal surgeon in Townsville, so did not want the surgery done there.
Right.
Because ideally it would have been done at Townsville, where you have the specialists there, you've got the ICU, you've got everything you need, but she did not want the surgery to be done there.
Yeah. Yeah. Okay.
The coroner found that the surgeon had another error in judgment in performing the surgery in Mount Isa Hospital, and that he and the anaesthetist did not have the right experience or facilities to do the surgery there. The anaesthetist accepted the coroner's criticism and put the failings down to oversight and the lack of clear policies or leadership in the anaesthetics department at that time.
True as well, because, he was expecting advice then if he got himself into trouble. He's not the most senior person there. It should be someone else I can call upon.
Yeah. So a new anaesthetic director had only recently arrived and they'd been relying on locums before that. So there was just inconsistency in the way the anaesthetics department was being run.
Yeah.
Because you've got a whole bunch of different people coming in and out.
Yeah.
The common approach to the surgery that was done is to make an abdominal incision first, to mobilise the colon and the upper rectum, and then make a perineal incision to divide the remaining tissue and remove it.
Yeah, because then he wouldn't have had to have sewn up the end that then ended up collecting all of the blood as well, right?
Yeah, and you'd be able to see properly at the top, get as far down as you can, and then only go a short distance up from below.
Yeah. That makes sense.
Yeah. The surgeon's reasons for not following the normal approach were he wanted to avoid making another incision if possible, because she'd had so many abdominal surgeries.
Right, fair.
He thought he could safely remove all the tissue from below.
Yeah. Are there instances where people would do it entirely without an abdominal incision, or was this a new approach in terms of trying to do it without the abdominal?
We will get there shortly. But yeah, that does come into it. He didn't want to divide the adhesions in the abdomen from the previous surgeries. He thought that the remnant colon may have shrunk down into the pelvis, making its removal without an abdominal incision possible.
Is that something that commonly happens?
I've got no idea.
They
did not go into that. Cool. He does not accept that the abdominal approach reduced the likelihood of unintended damage to vessels. So he was saying it's just as risky.
You can say that, but even if it didn't have any effect on the amount of bleeding that happened, the way you did it still meant that it collected without anyone noticing.
Yeah.
That it was pooling without anyone realising she was bleeding.
Yeah. And he thought it was easier to pack the pelvis if any bleeding does happen. One of the experts said that it was possible to follow the approach the surgeon did, as long as the person performing the surgery did not proceed further than they could safely, so approximately mid to lower rectum.
And where did he go to?
Good question.
But you basically said he got to a point where he couldn't see anymore, so I'm assuming that's possibly...
Yeah, he went 30 to 40 centimetres, which would have been past the end of the rectum, I would assume. He would have been into the colon at that point. I feel like a rectum is not 30 centimetres long.
12 to 15 centimetres. So, he's gone twice as far.
Yeah.
Yeah, okay.
Whereas they're saying you should only get sort of part way up the rectum.
Okay, so you should have only gone, 7 centimetres.
Yep.
Okay.
Another expert stated that the procedure should only be completed by performing the abdominal incision first to free the colon and upper rectum, then going in through the perineal incision. He said that the approach used in this instance was dangerous and unwarranted. So, in the inquest, the counsel for the surgeon submitted evidence that the approach used was taken from a textbook published in 1980.
Oh, yeah? I mean, look, things may not have changed in that 20 years.
I have to quote the current verbatim here as to what they thought about that
I'm looking
part
forward
of the
to
textbook.
I disagree with your assessment.
Mm-hmm. So they said, it contained a fascinating description of the development of colorectal surgery techniques in the 18th, 19th and early 20th centuries. However, I consider the opinions and habits of currently practicing specialists more persuasive than a text written in the 1970s when determining standards appropriate to practice in the 21st century.
So are you saying as well the technique that he was following was actually a technique that was described in a 70s textbook from previous eras as well, or was it describing what the current technique had led to?
I think it was describing the technique that he used as being the most up to date.
Okay,
but
so
I think it also included some other information about what used to be done. Yeah. The surgeon's evidence about whether it was surgical error which caused the bleeding and where and when that bleeding occurred was not consistent. So some of the surgeon's comments sort of in the initial letter to the coroner and then at the actual inquest, they included the hemorrhage was immediately apparent. He was unsure whether it was a result of the perineal or abdominal dissections. He didn't accept that he necessarily damaged the veins at all, and that the bleeding may just have flowed from the rectum separating from the sacrum. A clotting disorder could have caused the bleeding from the incision of small vessels, which
You'd
is
have to
not
have
normally
some
a problem.
coags to know that answer.
Yep. The perforation occurred in the middle of the dissection fascia when he was working from the perineal incision. So it's basically...
He doesn't know.
He doesn't know.
Or retrospectively, it's been enough time that he's convinced himself of something different. Again, whatever was written in the peri-op note, I always would take as the most accurate because that was what was written at the time.
Yeah.
But then I think back to one of our recent episodes where the midwives went and changed the records.
Yes.
So
he did concede that he wouldn't have seen the bleeding since the perineal area was draped when he started the abdominal incision.
yeah.
So even though he's saying, I noticed it as soon as it happened, but then he's also like, well, I actually wouldn't have seen it because that area was draped and I was in the abdomen at the time.
But they said there was a collection of blood.
There was pooling in the sacrum, and like he had temporarily closed the perineal incision as well.
Yeah, was it pooling and collecting in that closed space?
Well, they said he was surprised to find significant bleeding, but I'm not sure whether that was before or after he reopened
Okay.
the perineal incision.
Right, okay.
Yeah. In terms of blood pressure, it was hard to interpret the readings because of the anaesthetist's charting. The charting of the IV fluids were inaccurate in some respects and difficult to understand in others.
So just unclear what volumes of fluid she actually received along the way.
Yep.
Cool.
The amount of anaesthetic agent being used was also variable, and this could influence blood pressure.
Yeah, fair.
The coroner concluded that the bleeding started when the surgeon was working from the perineal incision, but he didn't notice it until he went back to that incision,
Yeah, agree
and
with that.
it had time to accumulate
Yeah.
by that point. However, he did everything reasonably possible to respond to the bleeding,
Yeah, fair.
and that he
fair.
was trying to find the vessels to tie them off and stop the bleeding, but he wasn't able to. And potentially, if he'd noticed earlier, he might have been able. So, like, from the point that he recognised the bleeding, the coroner was like, he did everything he could for that period.
Did he order more units of red blood cells?
And
though?
that didn't really go into that.
He did everything he could surgically.
Yes, and I think the anaesthetist was sort of the one who was responsible. The anaesthetist stated that he was prioritising fluid administration rather than blood transfusion, but an expert witness said it was difficult to know what should have been prioritised without knowing Annette's haemoglobin level before the operation started.
Agreed. If there was no hemoglobin, who's to know?
Yeah.
She started with a hemoglobin of nothing, and then she starts bleeding a little bit, then sure,
Yeah.
you're going to jump straight on to giving blood.
Yeah. The expert said that once the blood test results from 3:20 p.m. were known, at least 2 units of blood should have been transfused immediately.
And they transfuse them
They
over
weren't.
like a period of time, right?
Yeah, and it didn't really go into how many units of
Actually.
whole blood she got.
Yeah, right.
They also said that Annette should have been given at least 12 units of fresh frozen plasma, and blood tests should have been ordered hourly to monitor hemoglobin and other levels.
Yeah. And we only have like one single hemoglobin in this whole time.
Yeah.
Yeah, okay.
The anaesthetist's treatment of the bleeding was not satisfactory, but the expert stated that even an experienced anaesthetist would have trouble improving the outcome while there was ongoing bleeding. So essentially, he could have done better, but without stopping the bleeding.
Which the surgeon never really truly did.
No.
He
that's
just
right.
wrapped her up and sent her back
just-
to
yeah.
ICU.
Packed it, and I assume was hoping that it would just clot.
Off. But we also then don't know what our coagulation factors were doing.
Yeah.
So
Until
might not have
got those
clotted.
at 5 p.m.
Yeah, okay.
Yeah.
Okay.
The local coroner passed the case on to the coroner who did this inquest, as they didn't have the court time to hear the inquest and write the findings. So this meant, in this coroner's mind, there was an unacceptable delay in the inquest taking place because it was only heard in October 2008.
Oh, wow, okay.
I don't know,
So
that's only
almost
4 year
4
difference.
years.
How many coronial inquests do you see that are like less than 4 year turnaround?
Most of them?
Yeah, and I feel like especially for this one where there's not...
It's not
Yeah, it's
It's
not
not huge in
complex.
terms of...
Yeah, I'm thinking
yeah.
of things like the Adelaide show one, but again,
Yeah,
that,
but
that's different. It's
that's a
huge.
different
It took a long
kettle of
time.
fish.
And
Yeah,
a whole
this
bunch
is
of
like-
different
yeah,
departments, whereas this is literally
Just-
this hospital
Yeah, yeah,
and
fair.
these 2 doctors.
Yeah. 3, the junior house officer was there.
Oh, they didn't talk about them in the inquest. They weren't named. After the death, the hospital adopted the statewide clinical capabilities framework. Mount Isa Hospital is a level 1 hospital under that framework. This means that abdominal surgery, other than caesarean sections, is only done in emergencies.
Oh, wow. Okay, I imagine that's a moderate change.
Yeah, so clearly they were willing to do essentially elective surgeries there before, but now they said,
it's like, nah.
No, emergencies only, unless
Okay.
you have a Caesar.
Yeah, right.
Yep. A properly functioning morbidity and mortality committee has also been established. The coroner concluded that Annette died as a result of an inappropriate operation being undertaken by an insufficiently experienced surgeon in an inappropriate fashion while being assisted by an inadequately experienced anaesthetist who made basic errors from the outset.
It's a pretty damning statement.
Yeah, I thought that was quite...
Strongly worded.
Yeah, I'm not going to say it's not harsh, it's just...
Yeah.
Yeah, very much to the point. However, the surgeon didn't actually want to do the procedure, but was pressured by Annette and he agreed to try and help. He believed that he was capable of completing the procedure safely in the way that he did it. The coroner said that he didn't receive the support he should have from the colorectal surgeon in Townsville.
Yeah, it's so hard. If the colorectal surgeon already knew that Annette didn't like him.
Yeah. But he could have told the surgeon at Mount Isa, you should not do that procedure at Mount Isa.
Yeah. But the person in Townsville doesn't necessarily know what resources are available in Mount
True.
Isa to know whether that's suitable or not. You kind of got to have a little bit of faith in what the surgeon in Mount Isa thinks is reasonable to do.
The anaesthetist was experienced enough to recognise the errors he had made and gave evidence that he had significantly changed his practices since Annette's death. He was only working in the hospital 1 day a week, and there was a lack of policies and professional leadership in the anaesthetics department, as I've mentioned already. So he acknowledged that
That's good
he
that
did
he's
make a mistake and he
Yeah.
had changed the way he did things from then on.
Sorry, I was expecting you to be like, and because of all these failures, he just doesn't do anaesthetics anymore.
No, I think he still does.
Yeah, okay.
The coroner thought that the Medical Board of Queensland could conclude that the surgeon and the anaesthetist engaged in unsatisfactory professional conduct, and therefore he referred them to the board.
Yeah, that seems fair.
Seems reasonable in this circumstance. The surgeon was investigated by the board in relation to Annette's death and the death of another woman in 2005.
Oh, okay.
So a year later. So this woman presented with abdominal pain, but he discharged her without examining her or following up on the x-rays he had requested.
That's not ideal.
5 days later, she died from septic and hemorrhagic shock as a result of abdominal bleeding and peritonitis.
Okay. That's pretty extreme.
Yeah.
Yeah, less than ideal.
Yep. The surgeon retired in October 2008, but worked as a surgeon for another 18 months at the request of Queensland Health.
Oh.
I'm guessing because they couldn't find a replacement
Yeah.
for him. If he's the
area.
director of surgery, they do need to replace.
And it's an area that's not
Rural.
gonna, yeah.
Yeah. The Medical Board Tribunal began in 2012 and ended in 2013. And he advised them that he would never seek to reapply for registration.
So that, no
Yeah.
outcome from them because that's not necessary.
Yeah. The board noted that if he had still been registered, they would have suspended him and imposed conditions on re-registration.
Which probably would have been like, you can't work rurally without supervision. But
Yeah.
Queensland Health were like, please, we have no one working here.
But they hadn't decided that by 2008 when he was requested to work longer.
Yeah.
The tribunal hadn't started yet, so
Yeah, I know, but it's just
there
like,
were no
It's a bit of a
conditions.
double standard.
Yeah,
Yeah.
this is my issue. People that maybe shouldn't be working
Mm.
in a rural area because they can't get anyone else to work there. But is it ethically appropriate to have substandard care
Yep.
just because you live rurally?
Yeah.
Yep. Absolutely.
No, I agree.
The anaesthetist is still registered with APER with no conditions, and I couldn't find any information on adverse findings from a tribunal. So I think for me, this case is quite interesting because it touches on a number of issues that are really still ongoing, like the accessibility and adequacy of healthcare in rural areas.
Yes.
Still a massive problem
Problem.
because it's hard to get doctors and nurses out there.
Yeah.
Mm.
Yeah, and I don't know that that's necessarily changing anytime soon. I hope it is. But
And I don't know what good solutions there
I was
are
about to say, what are the solutions
entice
to that
people
problem?
out there, because they have these incentive programs where we're incentivizing people, but again, they may not necessarily have the skill or the support out there to be doing these things. So yeah, no one's come up with a particularly good solution.
Yeah, and the coroner
So-
didn't make any broad recommendations in terms of that. He was mainly just focusing on this one case. The other thing with this one that I found interesting was just the fact that it's easy to say she clearly had neuropathic pain, but that was something that wasn't investigated. And, we've got a history of women's pain not being investigated properly. Like, they believed her in this case that she did have pain, but it wasn't investigated properly.
Yeah,
and so
they
that
didn't
comes
look
back
at
to
what
that.
other sources were. Well, they always just referred back to what procedures that she had, so therefore it must be related to that without going into other causes or
proper pain management
options.
Yeah.
That don't always have to be surgical.
Yeah. And so I think that was definitely
But it's hard because it sounds like she seemed very convinced that they were surgical, that with surgery. But then her psychologist had said that she was accepting of the fact that
it may not
fix everything.
Yeah.
Which is hard to reconcile when she then wasn't willing to try things that weren't surgical.
Yeah.
In that one instance, I guess. But yeah.
Yeah, I just thought that was, interesting from that point of view of I think we are getting better with that sort of thing, but I still don't think it's foolproof or, it's still not. Women's pain is generally better considered now, I think, but still not
necessarily 100%. Well, didn't she still get something diagnosed as a hysterical problem anyway?
That was
like
talked about earlier.
Something.
Yeah.
Yep. So.
Yeah. So. But and maybe that should have been a trigger to, not saying that naming anything hysterical is a good idea, but if someone was not convinced by the problem that alternative avenues and thoughts needed to be considered because it didn't fit the typical. Doesn't mean that it was imaginary. It just means that, like, okay, well, this doesn't fit what would normally happen, so therefore we need to think outside.
We need to do some more investigations.
Yeah. Interesting. I have so many questions about that sort of end few hours of, like, so they were just like, we're done here. It
sort of seems that way. It sort of seems that they're like, yep, tried everything we could. Now she's going to die.
Yeah. It seems bizarre.
And, like, it wasn't discussed at any point that they were considering, like, medevacing her anywhere.
Yeah, and, like, retrieval advice from anyone being like, she's bleeding, can't get it to stop. What do I do?
And it didn't seem that the surgeon was involved in her care after
Post-op.
He
he just was like, bye.
Then it's the anaesthetist problem, and the anaesthetist didn't have the support
that they
from
needed.
Their senior person.
I know, it just doesn't feel like she needed to have died.
Yeah.
That they very much were just like, this is very different to all the previous stories where we're like, and these people went to these heroic measures, and even then they still couldn't revive her. And again, that makes it sound dramatized like we're on a TV show. But I don't know, a lot of the ones that we read seem that way, right?
Yeah.
Anyway. Yeah. Interesting.
Well, thanks everyone for listening. We will catch you again soon.
All right.
Bye.
Bye.